Okay, we'll start the today's session. I think without fluids, I think there is no medicine. And how many of you feel that fluid is a drug? Is there any doubt in this that fluid is a drug? You can answer. So someone answered fluid is not a drug. Okay. Others? Someone is feeling fluid is a drug. So that's only two answers. The rest of all not feeling anything. So could be drug, could not be drug. Okay, there are two votes for drug, one vote for no drug. So I'll go with the fluid is a drug. So if you feel fluid is a drug, so what you need, how to prescribe it? Say you are prescribing an anti-inflammatory or for fever, you're prescribing paracetamol, or you're giving an antibiotic. So what are the precautions you take when you prescribe a drug to any child? Come on, I'm not asking any extraordinary questions. I'm asking just basic questions. So what are the things you will see when you, yeah, good. You want to calculate, you want to give the right dosage. So first thing is you want to see in anti-inflammatory, what is the correct drug I have to give? Whether I have to give paracetamol, either give brufen, either give diclofenac. Like that, you need to choose. Apart from that, dosage. So you need to see the right dosage and whether I am giving a right drug to a right disease. So that is what we need to see. So like that, fluid is also a drug. It's a group of drugs. So you need to choose a right composition of fluid so that it will fits for the underlying problem or deviated pathophysiology which is affecting that child. So with this basic introduction, we'll move on to the therapy. So we'll go through certain physiology about fluid and water in the body. So there is a total body water. How much is the total body water content in a child? Rough estimation. Total body water. Okay, 60 to 70%. Okay. Is there any variations with age? Who will have major water, major percentage? Which group of children? Yes.
So newborns will have more total body water when compared to elder children.
Yes, exactly. Agreed.
Half an hour in my class, I found. The class.
Samsung SM, can you mute yourself? That is a representation of total body water. So you can see here when you start like intrauterine, it is almost 95%, and when you reach to term birth, it is almost reaching to 80%. So with child grows with age, with child comes to puberty, it's almost reaches to 65%. And once it reaches the adult phase, males will have a little higher percentage, around 60%. Females will have a little lower percentage because of excess fat content. It's around 55%. Starting with the term child 80 and preterm will have a little more percentage towards 90%. So infants will have little higher, and children will come near to say around 65%. So that is what your total body water. So it's around 65% of your body weight. In that, you will divide it to two compartments. The two compartments. So one compartment is the fluid inside the cell, and other compartment is fluid outside the cell. So fluid inside the cell will be normally in children and adolescent group, it will be higher. But when you see in the fetal period and preterms, so intracellular fluid will be lesser amount than extracellular fluid, and towards like 3 to 4 months they will become equal, and after that intracellular fluid percentage will keep increasing and extracellular percentage will come down. This is very important for us to understand the pathophysiological changes in the each compartment of fluid. So fluid compartments already we discussed. So intracellular accounts for 30 to 40%, and extracellular accounts for 20 to 25% total body weight. It is not a percentage of the total body water. It is a percentage of per body weight. In that, the plasma percentage is 5%. So if you have plasma percentage of 5%, what will the blood percentage for total body weight? So to answer this question, what you need? You have a plasma composition of 5% of the total body weight, and what I am asking is what is the blood volume percentage to total body weight, total blood volume. So to get the answer, what is the thing you need? Think. I'm not asking anything extra. What is the difference between plasma and blood? What is there extra in blood apart from the plasma? Yeah, cells and RBC. So you need to have hematocrit. So take hematocrit of 40%. So you, with a hematocrit of 40%, what could be your blood volume? So fluids is nothing but calculations. You need to calculate. So you need to start calculating. So plasma is 5%. So blood volume will be less or more. We'll start from there. Okay, it's going time. So the hematocrit of 40%, it's roughly it comes to around 8% of the total body weight. What does this 8% means? The 8% is how much ml? So how much ml per kg? So your blood volume is 8%. So how much ml per kg you are talking about? Come on, these are basics only I'm asking. I think everyone has go through this. Without this percentage calculation, you cannot do dehydration correction. I'm not asking anything extra. So without percentage of converting percentage into ml, you cannot do dehydration correction. So you should understand this. So how to convert this 8% body weight into volume? So what is the, say 1 kg is equal to 1 liter. So that's a rough estimate we'll take. On the normal circumstances, 1 kg body weight is equal to 1 liter. So 8% of your body weight. So you have to convert that 8% into volume. So you take 1 kg equal to 1 liter. So say your body weight is 10 kgs. So 10 kg means 8% of 10 kg. How much is 8% of 10 kg?
It 800 ml.
Yeah. So it's roughly corresponds to your 80 ml per kg. So you calculate like say 800 grams, you make it 800 ml. So you just to convert 8% into 100 ml per, make 10 ml, 10 ml into multiply into 10 into weight. So 8 into 10 into weight is what you get. So if you have 8%, your calculation is 80 ml per kg. If you have 10% dehydration, the calculation is 100 ml per kg. So just to multiply the percentage into 10, so that the thing. For actual calculation, you have to grow by 1 kg is equal to 1 liter. Then 8% of that body weight is equal to that much ml of dehydration. So that is what you need to do. So for simple remembrance, just remember that just multiply percentage into 10. So that will give your total percent of dehydration or total percentage of the body weight. So 8% is 80 ml per kg. So that is what normal blood volume you see, 80 ml per kg. I think there's no confusion here. The percentage to conversion into volume. So there is a delicate equilibrium between your intravascular fluid and interstitial fluid. There will be keep on shifting between intravascular and interstitial fluids. So what makes this shifts is your hydrostatic and oncotic forces. Your hydrostatic force is the pressure inside the vessel, which will keep moving the water outside, and oncotic pressure is the one which will keep the water inside the vessel. So there is a balance between these two things, which will keep the water in the equilibrium. So if there is any imbalance between these two things, like example, you have an hypoalbuminemia. So which is albumin is a major determinant for oncotic force. So if you have hypoalbuminemia, your oncotic pressure will come down. So even with a normal hydrostatic pressure, your fluid will move out and you get edema, interstitial edema. Or if you have a renal failure and your blood volume kept increasing. So blood volume is the major determinant of hydrostatic pressure. So if you keep increasing your blood volume, the hydrostatic pressure will go up, and even with normal albumin level and oncotic pressure, the filtration will happen and you will have get edema. So that is the two major mechanisms of your edema formation. One is increased hydrostatic pressure or decreased oncotic pressure. So you should have an equilibrium between these two to decrease these shifts. So coming to electrolyte composition, so your plasma will have more sodium and the intracellular fluid will have more potassium. So this is very important when you're dealing with electrolyte imbalances. I am not going to talk with them. So one more important aspect is osmolality. So your intracellular fluid and extracellular fluid will be in osmotic equilibrium always, because the cell membrane is permeable. So if one compartment has a change in osmolality, automatically other compartment will compensate for this and try to get the equilibrium. So the normal osmolality is 285 to 295 osmoles, and you can calculate it. It will formalize 2 into sodium plus glucose by 18 and 1 by 2.8. Here in glucose and 1 is in mg per dl. So you can calculate this. And normally this calculated will be slightly lower than the measured, and it usually should be less than 10 milliosmoles. And if the gap is more than 10 milliosmoles, you need to think of this unmeasured osmoles are there, like ethanol poisoning, ethylene glycol poisoning, sorbitol, and if you're giving mannitol. So these are the common examples where you have this difference of osmolar gap more than 10 milliosmoles. Just forget about this. Then we'll go to proper fluids. And what are the goals of maintenance fluids? Why you have to give maintenance fluids for any child? So what is the reason for giving fluids to a child? Maintenance. What you are maintaining, why you call it maintenance?
So to compensate for normal losses in the body, and everyday losses.
Good. Next. When you start maintenance fluid usually? Yeah, to prevent dehydration because of losses, to prevent electrolyte imbalance. Good. Normally, when you start maintenance fluids, we give maintenance IV fluids for every children coming to hospital.
No, sir, when child is on NBM, we will start.
Yeah, so what extra you have to maintain there when child is NBM? Apart from maintenance of this fluid losses and electrolytes, what do you have to maintain? Yeah, child is
Yes, sir.
what do you have to maintain?
Circulatory intravascular volume.
Yeah, apart from the
Nonsense.
fluid level, you have to maintain glucose levels. So you need to provide dextrose also. And the dextrose is to a certain extent that it should prevent the ketoacidosis formation. So these are the goals for your. So one thing is to prevent dehydration because of the losses will be there, and to prevent electrolyte disorders, and to prevent ketoacidosis, and the last thing is to prevent protein degradation. So this is the main goals for your maintenance fluids. And the glucose in the maintenance fluids roughly provides 20% of the normal caloric needs of the child. So if any child on maintenance IV fluids, he will be receiving inadequate calories because just you are providing 20% of his needs. So every day he will lose a weight by 0.5 to 1%. Even if you're providing adequate volume, he can decrease his weight by 0.5 to 1% because you're not providing adequate calories. So there's a protein degradation. So if any child has to be on maintenance IV fluids for more than 4 to 5 days, you need to think about starting TPN for this kind of children. So, so roughly we get that if any child needs more than 5 days NBM, we'll start them off on TPN. So for 2 to 3 days NBM, you can usually wait and watch with maintenance fluids. But if any child is receiving need to be an NBM for more than 5 days, try to put them on TPN rather than just to give maintenance IV fluid because they lose the weight every day with only maintenance IV fluids. So how to calculate maintenance water or what is maintenance water? So in the maintenance fluids, the water is the main component. So why you have to give water is to replace the obligatory daily water losses. So the main water losses are measurable and unmeasurable. So measurable water losses are like urine and stool. Non-measurable are insensible losses. It can be from skin or lungs. So the major component of water loss is from urine. It comes from 60%. Insensible losses, it will be only 35%, and stool is very low, it's 5%. So our goal for maintenance water is to provide just enough water to replace these losses. Like if you lose 500 ml, to replace with 500 ml of maintenance water. So how to identify this, how much your water is going to lose, will come in subsequent slides. And one more goal for maintenance water is to provide enough water so that kidneys no need to function more. Like they should not dilute the urine, or they should not concentrate the urine to balance the total body volume. So if you're providing excess maintenance water, they need to dilute the urine to flush out the water. If you're providing less maintenance water, they need to concentrate the urine to maintain the losses. So that's why you need to design your maintenance water to a certain extent that you should not make your kidney work more. So how to calculate maintenance fluid? What are the common formulas we have?
Holiday saga formulas.
What is that? Yeah, we have to move on. Time is running up. Pick.
So for the first 10 kgs, it is 100 ml per kg, and for the next 10 kgs, it is 50 ml per kg. After that, it is 20 ml per kg, sir.
Okay. What? How they design this Haldane-Sagar formula based on what? How they design this 100 ml per kg, then 50 ml per kg, 20 ml per kg? Is there any rationale for that? Or just simply they design and they written like that? Okay, is there any other formulas? Someone told 4-to-1 rule. It's a modified Haldane-Sagar formula only for getting hourly calculation instead of 24-hour calculation. Is there any other formula? Usually in cardiac children, we use that formula. Till now, we are talking about body mass. Is there another thing we can provide formula? Any other measurement of the body? Other thing is body surface area. So you can use body surface area method, that is 1500 ml per body surface area. So mainly we'll use this for treatment in post-op cardiac children, also in commonly in leukemia children. In leukemia children, you usually give 3 liters per meter square per day. That is what we, because you need to hyperhydrate them. And your Haldane-Sagar formula is based on caloric expenditure. It's a basal metabolic rate. What is your basal metabolic rate? Usually the body surface area for infants will be high. That's why infants will need higher amount of water to, because they will be losing more. And once the age is improving, your body surface area approximately will come down for that weight. So you need less water. So the principle is for Haldane-Sagar formula is your basal metabolic rate, that's based on caloric expenditure. And there's a last method, which is insensible plus measured losses method. Insensible losses is usually 400 to 600 ml per meter square per day. And you can measure urine output. If you have a catheter, you can measure urine output, and you have to replace ml per ml urine output. And if you have any other losses from GIT, like diarrhea or normal stools, you can measure that amount and you can replace that. This is called insensible plus measured losses method. It is very useful method in case of AKI, where you have nil urine output. So you need to just replace your insensible water losses plus stool losses. So you usually will give 400 meters square per day as insensible, and you will see the stool losses and you will replace it. Like if you have anuria, if you have little bit of urine output like oliguria, you can measure the urine output and replace it. So what is the modification for obese children? Can we take the full ideal, that is a normal weight for obese children, calculate this Haldane-Sagar formula, or you need to modify this formula? You need to take for the ideal body weight. So how to calculate ideal body weight is, so what is the 50th centile of body weight for the child's height? That is what you need to take. And there is a maximum cap for anything. So it is 2.4 liter for any size of the patient. How much is the weight? How much your 50th centile of body weight? So the maximum cap is 2.4 liters, and that is 100 ml per hour. So that is the maximum cap in maintenance fluids. And coming to different types of fluids, what you have crystalloids, which is based on saline, and you have balanced crystalloids. The examples are Ringer's lactate and now the plasmolite A. And you have dextrose-based crystalloids, that is like 5% dextrose, 10% dextrose. And if you combine with NS, you have DNS, half DNS. And you have colloids, which is a different group of fluids. You have 5% albumin, 20% albumin, starch, dextran, and gelatin. So these are the common examples of fluids. In that, for normal maintenance fluids, we'll try to give crystalloids. We don't go for colloids. Colloids have specific indications, and colloids will be mainly used in resuscitation and plasma leakages. So that is the only area where you'll give colloids. And for normal maintenance fluids, mainly we'll prescribe crystalloids. It could be a dextrose-based crystalloid or a plain crystalloid. So in that, if you see the normal plasma composition, the sodium is around 140. And to maintain osmolality, its osmolality is around 280. So if you have a fluid which have osmolality is nearby to the plasma osmolality, it is called isotonic fluid. And if you have a fluid which has osmolality less than your serum osmolality, like if you see half NS, the osmolality is 155. So they are called hypotonic fluids. And if you have a 3% NS, it is a hypertonic fluid, which is osmolality of almost 1000. So if you have a hyperosmolar fluids, you need to give them through a central line, preferably, not through the peripheral line. And if you see normal saline, the normal saline has a sodium of 154 and chloride of 154. So they almost sodium and chloride is equal. So if you keep infusing normal saline, child might have developed hyperchloremic acidosis. So to compensate that, you have balanced crystalloids. In balanced crystalloids like English lactate, you can see the sodium content is 130 and you have a chloride content way less than the sodium. And even in plasma light A, your chloride content is way less. Sodium is 140 and chloride is 98. So mainly this will be like physiological to your plasma. So when you're replacing more amount of fluids, you try to match with the plasma composition. So now the studies are coming up to give balanced crystalloids even in resuscitation. Not only as maintenance, even during resuscitations, you need to try to give balanced crystalloids. That is what the advantage of balanced crystalloids to prevent hyperchloremic acidosis and AKA, subsequent AKA. So if you see here, you have an solution here in the dextrose containing crystalloids, half DNS, 5% dextrose with half NS. So what is the osmolality of this? What is the osmolality of this half DNS? I have marked this. It is 405. The osmolality of half DNS is 405. So now with this osmolality, what you call this? You call this isotonic, hypertonic, or hypotonic?
Hypertonic.
Hypertonic. Okay. Usually up to 400 to 450, you take it as isotonic. So by seeing this, you feel like it is isotonic, but actually half DNS is hypotonic. The reason here is why it is hypotonic, because the glucose in it will be metabolized. Once the glucose is metabolized, the concentration of sodium and chloride is 77. So it will become hypotonic. So that is the reason for putting these fluids in hypotonic. So don't get confused. Half DNS is hypotonic or 5% dextrose is hypotonic, because they will be the glucose in them will be metabolized easily and they will release a lot of free water. So any fluid containing dextrose, except if you have an NS in that. So all other dextrose containing fluids are hypotonic, even though they appear hypertonic and isotonic when in the bottle, but when they enter the body and once the glucose gets metabolized, they'll become hypotonic. They become like hypotonic. So usually they'll be classified as hypotonic. So we don't give them during resuscitation. So I think I'm clear on this. So we'll move on from here. So coming to the choice of maintenance fluids. So now everywhere the choice is moved to DNS, isotonic fluids, or DRL, because you need to give dextrose. You cannot avoid dextrose in the maintenance fluid, because one of the goal is to maintain glucose for the provide calories to the child. So the choice is DNS or DRL. So there is no half DNS in pediatric age group, even for a ward children. The concept is gone, and isolate P is obsolete now. So everyone forget isolate P. I think I have heard some few people are using isolate P. Even in newborn, the isolate P is giving away to half DNS. So in pediatric, forget about isolate P, forget about half DNS. So remember DNS and DRL. So if you have DRL, you can go for DRL. But if you have DNS, DNS is easily available. So for normal child in ward, with no pathophysiology, like child is kept NBM for surgery, so you can give 100% of the maintenance. But in post-operative children, the problem is they can develop SIADH, so they can retain water. So you need to restrict the fluids to 70 to 80%. And in ICU children, like sick children, every child will have SIDH. So you should not give 100% maintenance. You should restrict it to 70 to 80%. So normal ward children, you can give 100%. Rest of all children, you need to try to restrict to 80% or 2/3, because every sick child will have an element of SIADH. So in case with AKI, already we discussed this. So you need to give insensible water losses, that is 400 meters square. Then you measure the urine output and replace it ml by ml. The choice of fluid in AKI is half DNS. It's mainly because of the your sodium composition and urine concentrating ability of the kidneys will be lost. So the choice of fluid is half DNS. So normally we'll try to add 10 to 20 millifluents of KCl to your maintenance fluid if there is no contraindication, because the normal maintenance potassium needed is 1 to 2 milliequivalents per kg per day. So how much 1 ml of KCl contains?
2 milliliters.
2 milliequivalents.
So 1 ml contains 2 milliequivalents. So you want to give 500 ml of maintenance fluid. So how much KCl you need to add to give 2 milliequivalents per kg per day for a child?
For 500 ml, 5 ml is there.
Okay, so to if you are giving 500 ml maintenance means
5 ml of
like a 5 kg child. So you need 2 milliequivalents. 2 milliequivalents of 5 kg child is 10 milliequivalents. So to give the 10 milliequivalents, you need to add 5 ml. So for 500 ml, you need to add 5 ml. That is the way you have to calculate for the KCl replacement. Any child receiving more than 50% of the maintenance fluids, you need to measure electrolytes daily, and you need to alter the fluid based on the electrolytes. That's a dictum. You cannot allow a child to keep on receiving maintenance fluids without measuring electrolytes. So at least try to measure electrolytes alternate day. Without that, don't keep giving maintenance fluids continuously. The treatment should be individualized, and you need to have a careful monitoring. Without careful monitoring, you cannot prescribe the drug. So fluid is a drug. So the children will have complicated pathophysiologic derangement. So it's necessary to adjust the electrolyte composition rate of maintenance fluid based on your electrolytes and fluid balance. So fluid balance is very essential. So you need to match, you need to see what is the input, what is the output, and try to modify your fluid rate according to that in the next subsequent 24 hours. So what all things you have to monitor is, you need to monitor daily weight. Any child on fluids, you need to monitor daily weight. You need to monitor input strictly, and you need to measure electrolytes. Apart from that, you can consider urea and creatine. So if a child had urea, creatine, and say today urea is 40, and tomorrow urea it become 20, and sodium is 135 today, and it become 132 tomorrow. So what it mean? So for urea from 40 to become 20, and sodium 135 become 132. So what it is mean? Yeah, there is no plain NS. You need to always use dextrose for infants, but if in adolescent people where they can tolerate few hours of without dextrose supplementation, there you can try a plain NS. But half NS or half DNS, you should avoid in for normal children. Yeah, what is the answer? You have drop in urea and drop in sodium for a child who is on maintenance IV fluid.
volume overload.
Yeah, volume overload. So you should cut down the maintenance fluid. So that is why you need to monitor electrolytes and urea regularly. So to manage your fluid balance. If you have strict urine output monitoring, then there's no need to measure electrolytes and this. But if you don't measure, like for normal children or in secondary level, you don't measure urine output, at least try to measure electrolytes and urea. It will give a clue for you. And body weight. And for newborn, and there's a table. I'm not going to detail it is. So you keep increasing from day 1 to day 6. So finally you reach around 150 to 160, depending on the preterm weight less than 1 kg, 1 to 1.5 kg, more than 1.5 kg. You keep increasing the fluid day to day. And the choice of fluid is initial for day 1, it is 10% dextrose, and day 2 onwards, you can choose from 1/5 to 1/2 DNS. But you need to modify this based on your sodium concentration. Now we stopped using 1/5 DNS, and we are prescribing half DNS to DNS. So again, you need to monitor sodium because the renal load, salt tolerance of the kidneys in the neonate will be less. So you need to monitor sodium. You need to adjust the sodium based on.
Excuse me, sir. Just to tell, half DNS is not usually used
In
in pediatric patient. Now in neonate, we are giving half DNS.
yes, the reason is the neonates will have immature kidneys. The solute load which should be less for them. Pediatric patients, the kidneys will be normal, so you need to give isotonic fluids because there is element of SAIDH, so they can have they can develop hyponatremia.
Okay, sir. Thank you, sir.
Sir, is it 24 or 48 hours, sir? 10% dextrose.
24.
24.
The basic thing is here is newborn. You need just adjust based on your electrolytes and fluid needs. So there is no ideal fluid. It's not 1/5, it's not half, it's not full DNS. So you need to modify the sodium concentration based on your serum sodium and other things. So don't keep giving only one fluid, but any fluid if you are giving, you need to check the electrolytes. Electrolytes are must in any sick children. Even for a normal preterm, I think at least alternate day you need to check if you have resource constraints. So without checking electrolytes, don't keep giving same fluid. So it will be harmful.
Okay, thank you, sir.
So that's what I'm telling. Isolate P newborn is obsolete now. Even they are moving towards half DNS. But again, you need to modify your fluid based on your electrolytes and your fluid status. So keep changing your fluid. Don't use same fluid for days together. That's what the main aim. What I'm prescribing today. So what are the factors affecting maintenance needs? I'll move on. So you have increased water needs because of the losses from the skin like burns, fever. If you're giving phototherapy, radiant warmer, and if you have tracheostomy, you have lung losses. And if you have GIT losses like emesis and diarrhea, and ileostomy, you have GIT losses. If you have polyuria like diabetes insipidus, you have renal losses. And if you have surgical drain, you have drain losses. And where you have less water needs is when you put a child in incubator. And if you're supplying humidified air, like if your child is on a ventilator, you are giving humidified air, your water needs will come down, insensible water will come down. And if child is having renal failure, oliguria, your water needs will come down. And if a child is adequately sedated, the metabolic needs will come down. Hypothyroid, again, the metabolic needs will come down, so you need less water. So these are the conditions where you need to modify your water needs. With every 1 degree centigrade rise in temperature, there is approximately 10 to 15% increase in maintenance water because of the insensible water losses. So you need to try to compensate for them. So now we will move on to the assessment of dehydration. So this is from the recent Nelson Essential Pediatrics 2023 9th edition. So they classified it to mild, moderate, severe. For infants, mild will be 5%, 10% moderate, severe will be 15%. And adolescent, like older children, adolescent, it will be 3%, 6%, and 9%. So what are the symptoms? In mild, they'll have thirsty, they'll be alert and restless. In moderate to severe, they'll be moving towards lethargic and sometimes even drowsy. And if you see tachycardia will be absent in mild, they'll be present in moderate to severe. Pulses will be normal in mild, they'll be weak in moderate, and they'll be feeble in severe. Blood pressure normal in mild, will be in hypotension in severe. Moderate will be orthostatic hypotension. So perfusion will be compromised. Skin turgor will be keep on prolonging with increasing severity of dehydration. And the one thing is in infants, try to look for fontanelle. It will be useful for you. Fontanelles are depressed, that means the child is dehydrated. Even if the child other fluid status is not able to, because sometimes they'll have hypoalbuminemia and sometimes not able to assess the dehydration in malnourished. If you see fontanelle is depressed, even in malnourished child with edema, so you need to think about there is a dehydration. And dry mucosa, even in malnutrition hypoalbumic children, if you have dry mucosa, that's a sign of dehydration. So these are two important signs in malnutrition children where you're not able to assess the dehydration correctly. So you follow these two things: fontanelle, mucous membranes, and your perfusion. Urine output. These are the main things you need to concentrate to classify the dehydration in even in malnutrition. So now coming to fluid therapy and dehydration. In fluid therapy and dehydration is a three-pronged therapy. One of the prong is deficit, what the child already lost. So how to calculate this deficit? This calculation of this deficit is based on your dehydration assessment. So if you have moderate dehydration in infant, that is 10% dehydration. So the child is already lost 10% of his body weight. So we need to replace 10% of his body weight. So 10% of his body weight in infant, say for a 10 kg child, so you need to replace 100 ml per kg, that is 1 liter. So the deficit is calculated based on your dehydration percentage. So mild, moderate, severe dehydration, based on that you need to calculate the deficit. And the maintenance, you need to know the formula, Haldane-Thakkar formula. And the replacement is you need to see the ongoing losses. For a diarrhea child, if the diarrhea child is losing fluid, so you need to calculate how many episodes of diarrhea is there, and you need to to replace the ongoing losses. So the therapy is three-pronged. One is deficit therapy, what already lost. Maintenance therapy is for the normal maintenance, and replacement therapy is for the excess losses. So deficit therapy, say if a child is in shock, that is in severe dehydration, you need to correct the shock by giving isotonic fluid boluses. Once you correct the shock, then you correct the rest of the dehydration slowly. So that is based on your sodium. If you have iso or hyponatremic dehydration, you can correct it over 24 hours. And the choice of fluid is NS or RL. If you have hypernatremic dehydration, then the duration of therapy should be prolonged. It should be over 40 to 72 hours. Choice of fluid is half NS. So I have taken it from Nelson. And normally for diarrhea dehydration, what is the regimen prescribed by WHO is you correct the dehydration over 3 to 6 hours. If you see, ideally speaking, that regimen is mainly for the resource limited settings where they cannot assess the electrolytes, where they cannot see other things. To save the child, they blindly follow this regimen 3 to 6 hours of WHO. But if you have resources to measure sodium and measures to monitor urine output, measures to correct shock, and able to pick up shock early and correct it by giving isotonic fluid boluses, you should not correct it over 6 hours as prescribed by WHO. Correct it slowly over 24 hours. If you have hypernatremia, even you should correct it over 48 hours. Is there any confusion here? Is it clear?
Sir, the correction 8 hours, and 0 to 1 hour, 8 hours, 8 hours, and 16 hours.
Venkat Prasad, can you mute yourself? Dr. Venkat Prasad, Samsung, SM. Yeah.
So that correction division of the 24 hours period, 0 to 1, 8 hours, 8 hours, 16 hours is that.
You're talking about which regimen this is? Any reference for this?
In Manipal, we used to do like that, sir. So first 8 hours is the, first 8 hours is the half of the correction. Next 16 hours is the half correction.
There are so many regimens are there, but commonly followed regimen is WHO. WHO, if you have severe dehydration, the regimen is like 30 ml per kg. You should give over half an hour to 1 hour based on the infant weight. If less than 1 year, it is over 1 hour. If more than 1 year, it's over half an hour. Then remaining things should be corrected. 70 ml per kg should be corrected over, let's say 2.5 hours to 5 hours. That is what the WHO recommends. That is what usually followed many centers in the India, like many medical colleges. Even when I did PG in Jeepneur, I followed the same regimen. The problem with that is sometimes you're overhydrating the children. So that is what I felt. And the recent Nelson, what they given it to be corrected over 24 hours. And there is no division of first 8 hours and first 16 hours. Because you are already giving fluid boluses to correct shock. Once you corrected shock with fluid boluses, the rest of the deficit can be given slowly only. There's no point of differentiating it again to 8 hours and 16 hours to confuse again. To make it less confusing, you correct the shock. You need 3 boluses, you need 4 boluses, that is 60 to 80 ml per kg, you give it. Once you corrected the shock, then the rest of the dehydration, you can correct it slowly because you are already established the perfusion to the kidneys well. And now the kidneys will adjust and try to manipulate the fluid inside. And the rest of the correction you can give slowly. And I am not aware of this 8 hours to 16 hours correction, and I never followed it. If there is any reference for that, I think you can share in the group.
We used to follow a book called Red Book. There, first 1 hour is the complete dehydration, shock correction. Then divide the total fluid into 2 parts. First half should be given in 8 hours. Second half should be given next 16 hours. That's what the Red Book says. But this is also is followed. Just I'm
I understand.
correct.
Yeah, because no, it's not about correction. It's about reference. Because there's a different policies over the world. So which policy where they following this? Because Nelson is mainly from the US side. Sometimes like UK can follow differently. That's what I want to know. Because in India we never followed that thing wherever I did my PT and fellowship.
Okay.
So anything like if even for 8 and 16 hours, you are giving slowly over 24 hours rather than WHO, which will tell to give over 3 to 6 hours. So which will be many times it feel that we are overloading the child. Even for malnourished, you cannot follow this 3 to 6 hours regimen of WHO. You have to give it slowly. So ideally, so you give more 24 hours. That is what I can suggest, because you are already correcting the shock by fluid boluses. We can assess shock by clinically. So you need to follow the regimen. Even in WHO, the initial 30 ml per kg is for shock correctment. So anyway, you are correcting the shock by giving fluid boluses. So there's no need to follow the WHO regimen. So that is what I can suggest. If you are able to assess carefully and you're able to monitor electrolytes, try to follow this regimen, which is easier and which has less side effects. So this is what the regimen in the recent Nelson, they slightly modified this regimen. So what they told is you restore the intravascular volume. You give normal saline 20 ml per kg over 20 minutes. If the child is in hypotension, you can go follow this regimen, or even 10 ml per kg if the child is not in hypotension. And in the old Nelson, they are not given this thing. So they just told to calculate the deficit and give it over 24 hours. But in new Nelson, the 23 edition, they added this component here. Like previously Saad told, like one half you're going to give over 8 hours and rest of the half over 16 hours. They told to give another 20 ml per kg, even after correcting the intravascular volume, like you corrected the shock. Even after that, they told to give extra 20 ml per kg over 2 hours. I don't know what the logic for these 2 hours. I completely unaware of this. So maybe they're feeling that to give some rapid correction so that maybe the major shifts may not be, you're going to prevent the major shifts. So that is what I feel the logic behind this. And maybe that's something every time it's going to change. So the logic behind is once you correct the shock, you need to correct the rest of the deficit slowly. That is what the logic. So you want to correct it for 16 hours, 24 hours, 40, that's up to you. Until unless the child is not landing up in the shock again. And the major thing is you need to subtract the fluid already given. So if you're given 2 boluses and you're given almost 20 ml per kg, like 60 ml per kg you're given, you need to subtract it from the deficit. And then you need to add maintenance for the deficit. And one more fallacy in this thing is they told to give entire fluid as dextrose normal saline. But if you calculate deficit and maintenance and you are giving as dextrose normal saline, sometimes you can cause hyperglycemia and you can inadvertently cause polyuria. So what I prefer is you give deficit as NS, don't combine with dextrose and run it separately, and calculate maintenance and give it as DNS. For maintenance fluid, you can add KCl rather than adding for deficit fluid and maintenance fluid KCl. Sometimes you can overcorrect KCl and you can cause hyperkalemia. So this is what given in Nelson, but I will modify this for my use. What I will do is I will take 2 fluids. One is DNS, other thing is NS. I will calculate the deficit and deficit volume I will give as NS. And maintenance volume I will give as DNS. For the maintenance fluid, I will add KCl depending on the potassium status. If potassium is high, I won't add. If potassium is normal, I will add normal maintenance. And if potassium is low, I will add extra maintenance. That is 20 for normal maintenance. I will add 40 milliequivalents for extra maintenance. So I think I'm clear on this, what I'm talking. So instead of giving same fluid for deficit plus maintenance, we can overload the case here. You can overload the dextrose. You can divide them into deficit plus maintenance. Maintenance, you can do DNS with potassium, deficit plain NS or RN. And the most important thing is you keep replacing the ongoing losses. If you don't replace ongoing losses, you can make the child again land up in the shock. So once you correct the shock, child should not go back into shock again in the hospital. Even if child had 10 episodes of loose stools in 1 hour, the child should not go into shock again. So you keep replacing the losses, ongoing losses. So the hypernatremia management is certainly different. So here, in child is in shock, you need to restore the volume, and your rest of the correction is based on your sodium. So if you have very high sodium like 184 to 196, you need to correct it over 4 days. And if your sodium is like 145 to 157, you need to correct it over 24 hours. So depending on the sodium status, you need to correct it over how many hours you need to give the deficit, you need to decide. And normally, we don't follow the deficit correction. You don't calculate the deficit based on the dehydration status. Here, we'll just to follow, we'll give 1.25 to 1.5 times the maintenance. That is what normally we'll do. And we'll choose the fluid half DNS because you need to reduce the sodium. So we'll try to give the half DNS. And you don't calculate the free water. There are so many formulas in the Harriet Lane, and so many books are there in renal books and the Bagga. There's so many calculations are there. Simply don't waste your time on calculating formulas. Don't calculate the free water. Don't calculate deficit in hypernatremia. If you see sodium is higher side, forget about deficit, forget about the free water. Just to give half DNS at the rate of 1.52. If you have severe hypernatremia, you can even restrict the fluid to 1.25 times. And you need to keep monitoring your sodium and fluid status. You need to at least monitor sodium 4th hourly. You cannot correct hypernatremic dehydration without monitoring sodium. If you don't have facility for monitoring sodium frequently, please refer that child. Because the sodium monitoring is very essential. If you drop the sodium too fast, child can land up in CNS complications and child can throw a seizure or child can become vegetative state. So be careful when you're correcting hypernatremia. If you don't have facility for sodium monitoring, please emergently refer the child after correcting the shock. So the ideal fluid and ideal volume will be decided based on your subsequent sodiums. See here, if you have volume depletion again, you need to correct by giving bolus. And if you have too rapid drop in sodium, you need to increase the sodium in your. If you are giving half DNS, you need to change it to 3/4 DNS, or you can give DNS. Even after changing to DNS, your sodium drop is rapid. You need to decrease the fluid rate. So you started 1.5 times, now you drop it to 1.25 times. So based on the sodium only, we need to modify this. Don't need to calculate free water, no need to calculate any other formulas. And if your sodium is dropping very slowly, then you need to come down on the sodium percentage. So you say you are on 3/4 DNS, you come down to half DNS. You are on half DNS, you go down to 1/4 DNS. And you are on 1.25 times, you can go to 1.5 times. Usually you don't cross 1.5 times, but in very rare scenarios, you need to go up on the 1.5 times. And try to replace the ongoing losses. You need to keep replacing the ongoing losses. Never forget about ongoing losses. The main crux here is you should not drop the sodium more than 12 per day. Keep a target of 10, not even 12. Try to restrict yourself to 10 per day so that you don't overcorrect the sodium. Overcorrection of sodium is main problem. If you're correcting sodium very less, it's not a problem. But if you're overcorrecting sodium, it can lead to major problem. So that's why try to undercorrect the sodium than overcorrection, and try to monitor the sodium frequently, at least 4th to 6th hourly. So what is replacement therapy? Replacement therapy is for ongoing losses. It's ml to ml. In diarrhea, for small volume stool, we label it as 5 ml per kg. For large volume stool, we take it 10 ml per kg. In emesis, we usually restrict to 2 ml per kg. And you need to calculate it every 2 to 6th hourly and replace them. So for diarrhea, the fluid of choice is half DNS because the sodium content in the diarrhea fluid is less, and they'll have bicarb loss also. So you need to add bicarb 30 milliequivalents and 20 milliequivalents of KCl. So for vomiting, the sodium content is high, so you need to replace the fluid with NS plus 10 milliequivalents of KCl. So the diarrhea, the fluid is half DNS, replacement fluid, not the deficit fluid. Vomiting, it is NS. It is based on your physiological losses. So the next most important thing is what is the fluid volume to be given and rate in the shock. Say if you have a hypovolemic shock like dehydration, diarrhea and vomiting, if it's a compensated shock, you can give it over half an hour to 1 hour. You can choose 10 ml per kg. But in hypotensive shock, you need to give 20 ml per kg by push and pull. There's no replacement for hypotensive, you need to correct faster. And how many bolus to be given, there's no limit. If it's purely hypovolemic shock like diarrhea and vomiting, so there's no limit. But usually don't need more boluses because you can easily correct the hypovolemic shock because the intravascular shifts will be there, intracellular shifts will be there. So you don't need more than 2 to 3 boluses. If you are needing more than 3 boluses in a diarrhea child, you need to look for other things like sepsis, acidosis, blood loss, hypocalcemia, that are all things you have to look for. That is ABCS. Same distributive shock. Distributive shock is mainly due to vasodilatation. There also you can follow same principle, but the main treatment is not fluids here. The main treatment is vasopressor treatment. So you can restrict to 1 to 2 fluid boluses until you start a vasopressor. Once you start vasopressor, you should not give further fluid boluses. But if you suspect cardiogenic shock, you need to give fluid bolus very slowly and low volume, 5 to 10 ml per kg over half to 1 hour. So there you should start emergently inotropes like adrenal. You should not keep giving fluids, flushing fluids. Dengue and DKA, the treatment is different. I'm not going to concentrate on this. Go read it and we can discuss in later classes. Already dengue management, we already discussed it in the previous CBT, so you can go through the video. But for exam, you need to stick to it. In any exam, there is no compensated hypotensive shock. Shock means 20 ml per kg, over 15 to 20 minutes. That is what the old examiners will ask you. So how many boluses? 2 to 3 boluses in 1 hour. After that, you need to start either inotrope or vasopressor. This is for exam. For rest of all management, you need to follow like compensated shock, slow fluid bolus, hypotensive shock, rapid fluid bolus. So choice of fluid, crystalloid versus colloids, previously I told. So for normal thing, you can use crystalloids. For shock management, if you're needing more fluid boluses, you can consider colloids. The advantage of colloids is theoretically they can overcome the shock quickly, and because they increase the oncotic pressure, they can decrease the shifts of fluid, leakage of the fluid, so they can reduce the requirement of fluids, and they can restore the cardiac index faster. That is the only theoretical advantage. But if you do the studies, major studies, there is no clear advantage in the terms of hospital stay and mortality. So if the patient is affordable, you can try to give colloids, but the patient is unaffordable, try to continue crystalloids. But recent studies, when septic shock, albumin usage came up, not because of this hospital stay and mortality. What they found is albumin will support the disrupted glycocalyx, so they can decrease the fluid leak. So total amount of fluid given for a child will be come down. So that's why they prescribe albumin, rescue albumin in septic shock and dengue. So that is the only advantage of colloids apart from crystalloids. So with this, we'll move on to the case scenario. So we'll quickly discuss this case scenario. So you have 1-year-old child. I think you need to take a paper and pen with you, so to calculate the fluids. So you have 1-year-old child with multiple episodes of loose stools and vomiting for the past 2 days. The child had decreased urine output from morning. Child is found lethargic on examination. Child had depressed AF, eyes sunken, skin texture prolonged, mucosa dry. Heart rate was 180, pulse is feeble, CRT is 5 seconds, BP is 56/38 low. So weight is 10 kg. So what you're going to do with this child? Quick, we need to move on.
1 liter for the dehydration, 1 liter for the maintenance, and
No. What is the status of this child currently?
severe dehydration.
So what is the status? Child is in shock or not in shock?
Yes, shock.
Shock, how to correct shock? Child is in hypotensive shock. How to correct hypotensive shock?
Fluid bolus first.
Fluid
How much
bolus.
fluid bolus?
Only
20
1
ml
liter,
per
1000
kg.
ml.
20 ml per kg. I given a weight 10 kg child.
So
200
200
ml. 200
200
ml.
100 ml over
fast we will give within half an hour, sir. Half an hour to 1
Full
hour.
push.
Within 20 to half an hour, sir.
Yeah, it is no time. It is push and pull. If you can able to give 5 to 10 minutes, you can give.
Oh,
So in hypotension, it is push and pull. There is no time period. So you need to give push and pull. Before giving this bolus, when you're securing IV access, anything you need to do? When you're securing IV access, anything you want to do?
Medial
Syrup
tube.
electrolytes, sodium.
You need to send for electrolytes. Any apart from that, anything? Child is lethargic.
That's because we are not able to get IV line, then go for the medial tuberosity.
GRBS. GRBS.
Yeah, you don't forget
GRB.
GRB. Child is lethargic. And apart from that, if you have a source for access for an blood gas measurement, go for VBG. So IV cannula.
What is difference between VBG and ABG, sir? Only oxygen or other oxygen level, percentage of oxygen level? Or
If you are taking for respiratory compromised patients, you want to look for CO2 and PO2, you need ABG. When you are doing it for metabolic needs like this, to look for metabolic acidosis, even VBG is enough. No need to prick the artery.
Okay.
So we given NS bolus 200 ml over 15 minutes by push and pull. Okay. So these are the vitals after that. Heart rate is 160, pulses are feeble, CRT is 5 seconds, BP is slightly improved. Now it is 66 by 48. So what is the correct condition?
Slight
Shock
improvement.
corrected.
No.
Or is it still shock?
Still
Shock means what type of shock? Compensated or hypotensive?
Hypovolemic.
So child is still in hypotensive shock. What you are going to do with this?
Another bolus.
Another bolus, the same technique, push and pull. So with this, these are the vitals now. So heart rate came down to 140, pulses are low, CRT is little bit okay, 4 seconds, and BP is now 76. So now what is the region? Is it in shock or not? In what shock? Severity of shock.
Compensated.
So now what do you want to do?
10 ml.
So you need to give 10 ml per 100 ml over
15 minutes.
half an hour to 1 hour. I will give to over half an hour. I think I am clear on what I am talking. So if you have hypotensive shock, you need to give rapid push and pull, that is 20 ml per kg. And if you have compensated shock, try to restrict the fluid to 10 ml per kg over half an hour. And these are the vitals after the third bolus. So now what is the status of the child? Shock is cutted or not?
Improved.
So shock is improved. So now what is the fluid prescription you are going to give for this child?
DNS.
You need to tell me what you write for a sister. I am not a doctor now. I am a sister now. I cannot understand 1000 ml, 10,000 ml. So I need to know how much I want to give per hour and what fluid I have to give per hour. So that is what I need a clear prescription, because I am a staff nurse now. I don't know. I cannot calculate 1000 ml for 24 hours. So please calculate for me and tell me. So what is the therapy you are going to give for this child now? So now the child shock is corrected. So now you need to give deficit therapy and maintenance therapy. So how you are going to give that for a sister? Tell to a sister, not to me. Please measure and tell me. Sodium is normal. Yeah, someone correctly asked me what is the sodium. Good. So this is the electrolyte status for you. So sodium is 134, potassium is 2.9, urea is elevated, creatinine is elevated, VBG is showing some amount of metabolic acidosis. So with this background information and with these electrolytes, so what is the prescription you are going to give for a sister? So you need to tell me in a per hour calculation. Per hour, how much fluid you are going to give for a 10 kg child with severe dehydration. and this child already received 3 boluses. Don't need to consider the 2 hours 20 ml per take off the 2 hours 20 ml per kg. Just to concentrate, calculate for the combined deficit. So what is the deficit here? How much is the percentage of deficit here? Infant with severe dehydration?
10%.
It's 15%. That is what we discussed previously. It is 15%. So how much already we given? We have given 500 ml. So now what is the remaining fluid, deficit fluid?
1500 ml.
1000 ml. So you have deficit of 1000 ml. What is the maintenance fluid for this child?
DNS.
No. Calculate.
1000 ml
1000
DNS.
So now you tell me what we are going to tell the system.
DNS with potassium chloride adding. So for 500 ml of fluid, you'll have to
Yeah.
you'll have to add potassium chloride 5 ml
How much?
and 5 ml of potassium chloride to 500 ml
500 ml. And how much rate you want to give?
at the rate of 45 drops, micro drops per
45 ml per hour.
hour.
So that is for maintenance or deficit.
Maintenance
For deficit,
deficit.
what you are going to do?
10 ml per loss, sir.
Yeah, you can take a calculator and calculate. Young people are there. PGs. That is what you have to do. You are the persons who are going to write these prescriptions to sisters. So calculate and tell me what is the fluid you are going to give. So how many of you agree for this maintenance fluid of 45 ml plus 5 ml KCl? Is it 5 ml KCl or you need to do anything extra here? Because what is the potassium here? Potassium here is normal or low?
Low.
Low.
So low. So you need to up your maintenance potassium. You cannot give 5 ml potassium. You need to go up. So you need to add 10 ml KCl for 500 ml of fluid. So that is the first thing you need to change in maintenance fluid. Apart from that, for deficit, you can give NS at the rate of 40 ml per hour. So I calculated for you people. So this is what the prescription I need to write for a sister. So one side I start NS, which is a deficit fluid at the rate of 40 ml per hour. So total is 1000 ml. And for maintenance, I will give DNS and I will add 10 ml KCl for 500 ml. So to correct the hypokalemia as well. Everyone agree with this? Any confusion here? No confusion or anyone confused here? If no confusion, we move on. Time is going up. So after 2 hours, this child had 3 large stools and 2 episodes of vomiting. So now you tell me how we are going to prescribe replacement fluid for this child. So after 2 hours, child had 3 large volume stools and 2 episodes of vomiting. So how much each for large volume stool you need to replace? How much
100
volume?
ml. 100 ml.
So 10 ml per kg is 100
10
ml. So 3 large volume stools, so it is 300 ml. So what fluid you are going to give here? First, diarrhea.
Half DNS.
So half DNS with the addition of bicarbonate and potassium. Okay, you need to calculate, it's going to take time. So I'm going to move on. So this is what you're going to prescribe. So you add 300 ml to 300 ml half DNS, we add 10 ml bicarb and 3 ml KCl, and you need to give it over next 2 hours. You cannot give it like a bolus. You need to give it over next 2 hours. And same thing for vomiting, 2 ml per kg, you need to add NS with 0.1 ml of KCl. So totally 320 ml, you need to give it over next 2 hours. And in these 2 hours, again, you need to calculate how many stools are there or how many warm things are there. Again, for the next 2 hours, you need to replace the losses. If you have 5 stools in the next 2 hours, so your replacement fluid will go up to 500 ml. The commonest mistake is we will not concentrate on the replacement fluid. We'll forget about this. We'll calculate it, we'll correct shock, we'll put maintenance fluid, and then we'll go on, we'll see OP. By the time child will be keep losing the area, he will keep losing the water, and if you don't replace the ongoing losses, after 4 to 6 hours, you go and see the child will be in shock again. So that's what I'm telling. If the
Sir,
child is
ongoing losses on which line, sir?
ongoing,
I mean, this third one.
third
Through which
one,
line? Through which line?
you can add the same line, or you can put one more line. You can put a three-way tab, and you can continue. Because these are all IV fluids that are compatible with each other. You don't need to put separate 3 to 4 IV lines for anything. You can have a white bore cannula, or you can have 2 cannulas, and you can put a 3-way, and you can continue the same IV line itself. No need to change the IV line. So don't forget about replacement fluids. It's very important. So if you don't monitor the child, you don't address the ongoing losses, the child will go back again to shock. So that should not happen in the hospital. The child coming to you in shock is different, and child is landing up in shock again in the hospital is different. So you need to modify the replacements based on the frequency of stools. If the child had 5 to 10 episodes of stool in half an hour, your strategy should be different. You need to replace it in half an hour itself. The child is passing less frequent stools, then you can replace it slowly over 2 to 4 hours. So don't stick to the textbook guideline of 1 to 6 hours. You need to modify that 1 to 6 hours based on your patient. So scenario 2, quickly move. It's a 19-day-old child, neonate, 3 days history of food feeding and activity. Child was on DBF only. But now they tried cup and spoon also, but child is not feeding well. And the child had history of decreased urine output, and there's no output. Child was dull on examination, depressed, eye of sunken eyes, inner gut severely prolonged, mucosa was very dry, heart rate was 200, pulses are feeble, CRT is 5 seconds, BP is very low. Birth weight was 3 kg and current weight was 2.2. So what do you want to do next?
Your dehydration.
Okay. So what do you want to do now? Child is in shock or not in shock?
Sir, baby is in shock.
Hypotension or normotension?
Hypotensive.
So what do you want to do with hypotensive shock?
So we have to start again on the IV line and give the bolus.
So put IV line, send samples, and you have to give bolus. So bolus should be 20 ml per kg. By push and pull. But for this child, so what weight you have to take here? Forgotten question. The birth weight is 3 kg and current weight is 2.2 kg. So what weight you have to take for calculations?
Birth weight.
It's birth weight. It's never the current weight. The current weight is dehydration. So always try to get the birth weight. And what is the percentage of deficit here? Volume. What is the volume deficit here? Say it is severe dehydration. So for 3 kg child is 15%. So what is the deficit here? What is the volume deficit here? If you calculate according to the dehydration formula. So 15% for a 3 kg child is 450 ml. But if you see here, the birth weight is 3 kg and current weight is 2.2 kg. Why the weight is decreased? Reason for the weight loss is your dehydration. So in this particular child, when you have a birth weight measurement and current weight measurement, the dehydration is 800 ml. It's not 450 ml according to the formula. The formula will tell that severe dehydration is above 15%. 15% could be 20%, 25%, 30%. The minimum is 15%. So you need to think like that. So if you have a weight birth weight and current weight, you can easily calculate the deficit based on that. If you don't have that, you assume that the minimum deficit is 15%. Once you correct 15%, still dehydration is there, you can correct the rest later. That is what the calculations are based on. The minimum is 15%. So for this child, we given a bolus, and we found that child is having hypoglycemia also. So we given 10% dextrose, 7.5 ml by push, and these are the vitals after that. So BP improved, not become normal tension, heart rate came down. So what you want to do now? You need to give one more bolus, but this time we give you 10 ml per kg, that's 30 ml for half an hour. So these are the vitals after that. What is the current status now? Heart rate is normal, pulses are normal, BP is normal. So child, shock wise, child was corrected. So meanwhile, we got the reports. These are the reports. Sodium was 181, potassium was 6.9, urea 310, creatinine 3.9, pH was 6.9, bicarb was 6. This is a real life case what you got. So in our hospital, we manage this child. So what we're going to do now?
Hypernatremia and hyperkalemia.
So what is life-threatening?
Renal compromise.
So what is the life-threatening condition here? Hypernatremia, hyperkalemia.
Hyperkalemia.
Hyperkalemia and severe low pH, 6.9 is incompatible. So what are you going to do now? What are you going to do now? You're going to give fluid, or you're going to do something before giving fluid? We need to correct the hyperkalemia first. So you need to see the ECG, and with 6.9, definitely ECG changes will be there. And to stabilize the myocardium first. So you need to give calcium. So for yourself, I am going, so calcium, you need to give at least 1 to 2 ml per kg. So over 20 minutes, and you can give bicarb question, because the bicarb can shift the potassium inside, and in meanwhile it can correct acidosis. If you have acidosis, it can shift the potassium back. So you need to correct the rescue bicarb 1 ml per kg, and you can install in NAB. And meanwhile, also you can start insulin 0.1 unit per kg with a 10% dextrose over 1 hour. So this is mainly for potassium correction. Once you correct the potassium, then you need to start calculating the deficit fluid. So what is the fluid choice you're going to give here, and what is the amount per hour you're going to choose here? You calculate that and tell me. I think this 1.5 hour session is fruitful. Sodium is 181. So based on the sodium, how to write the fluid prescription. If you want, I will go back. So I will put that hypernatremic dehydration chart for you people. You can see and calculate. Yeah, please calculate based on this. So 3 kg child, sodium is 181.
We calculate in 22 hours. We will correct in 22 hours.
Yeah. So, okay. So what is the fluid rate you are going to give now? What is the fluid and what is the fluid rate you are going to give now? If you tell that, I will close this session. Yeah, it's already 6:30. We need to end this session. So one answer I need. So what is the fluid rate you're going to give per hour? I need in per hour. So half DNS is the fluid choice. What is the fluid rate? Take 1.5 times maintenance. Take 1.5 times maintenance, and you tell me the fluid rate now. What is the maintenance fluid for a 19-day-old child? Maintenance fluid for 19-day-old child.
150 ml per kg, sir.
Yeah, 150 ml per kg. So you need to add extra 50% to that. This 225 ml per kg. per day. That is what the sheet plus maintenance you are going to correct. So how much it comes to now for 3 kg chai? Can someone quickly calculate and tell me?
So 28 ml per hour, sir.
Okay. So we given the potassium correction. So we calculated it as a. So someone pointed out half DNS, but in this scenario, when you have a sodium of 181, even DNS is very hypotonic. So the sodium in DNS is 155, 154. So for a plasma sodium of 181, your 154 sodium itself is hypotonic. So that's why usually when your sodium is very high, above 180, I will try to put DNS instead of half NS. So it's a rough estimate only. Even if you want to start half DNS, you can start. There's no harm. If you want to monitor, if you're able to monitor sodium frequently every second hourly, you can give half DNS. But if you don't have facility to monitor sodium frequently, try to put DNS when your sodium is more than 175. Because even in NS, the sodium is 154, even that is hypotonic to your body fluid. So that's why always try to give a higher sodium concentration when you have severe hypernatremia, when you don't have facility for frequent monitoring. And second thing is, with this pH of 6.9, you cannot tolerate the child may at any point of time. So you need to continue bicarb correction. I am not going to talk about bicarb correction. There are so many formulas for the bicarb correction. If you go through that, we can discuss later. The main crux here is, don't calculate deficit, don't calculate free water. Just to follow simple formula of 1.5 times the maintenance. If you follow that formula, you can easily manage hypernatremic dehydration. And you need to frequently monitor the sodium and you need to adjust that thing. The last question is, after 4 hours, this change sodium is 180. So what you are going to do now? So from 181, you started DNS and this change sodium is 180. So what are you going to do now? Yeah, there is a renal failure. Child is already having creatinine of 3.9 and urea of 310. I think someone missed this previously. So urea is 310 and creatinine is 3.9. There is a hyperkalemia. There is severe metabolic acidosis. So that's why we given potassium correction, we given bicarb corrections. We are continuing bicarb correction. We started 1.5 times the maintenance. And this urea creatinine is not renal, it is pre-renal. Never assume that this is renal. If the child had dehydration, child had shock in with urea creatinine of this much, don't assume that it is renal and you don't think about correcting the child. Any child with this kind of dehydration shock will have pre-renal AKI. So don't worry about this high urea creatinine. This is actual values I given. This is not the fabricated values. We have a child with this much amount of urea and creatine, and with this fluid correction, child improved nicely within 4 days. Urea creatinine normalized. So don't worry about urea creatinine if you have shock and dehydration. So if you have hypervolemia, that the child had signs of hypervolemia, then you think about fluid restrictions. If the child had hypovolemia and you're thinking that pre-renal, you need to correct the dehydration. Don't worry about urea creatinine value. The second lesson you need to learn from today's talk. Assess the volume status and then you decide the fluid. So sodium is 180 after 4 hours. Child was on DNS. What are you going to do? Rate is 26 ml per hour. What are you going to do here? Come on, we need to end the session. What are you going to do? You can increase the fluid rate, probably, but already we are on 1.5 times. That's the maximum we can give. So we can. There's no option of increasing fluid here. But option is we need to decrease the sodium concentration. The sodium concentration you can change to either half DNS, but ideally what I can suggest is change to 3/4 DNS. The 3/4 DNS, if you need to mix half DNS with DNS. You can take that 13 ml of half DNS, 13 ml of DNS. Or ideally, hypernatremia management, you need to have two fluids. One is DNS, one is half DNS. And you need to keep adjusting the rate of the half DNS and DNS based on your sodium. You check the sodium is falling rapidly, you increase the concentration. Say now, say we started on 3/4 DNS now. That is 13 ml of half DNS, 13 ml of DNS. After 4 hours, our sodium is 176. So what we can do now? We are on 13 ml of half DNS, 13 ml of DNS. That is 3/4 DNS. And after 4 hours, we repeated sodium. The drop is 176. That means there is a rapid drop. So what you are going to do now? What we can do now?
Decrease the rate or increase the solution?
Exactly. So you can decrease the rate or you can change the solution because we have two solutions. What we can do is we can increase the rate of DNS. We made a rate of DNS into 18 ml and 7 ml of half DNS. Or you can decrease the half DNS rate. You can decrease the half DNS rate to 7 ml and continue 13 ml of DNS. That is depending on your fluid status. So what I feel is most probably I can increase the sodium concentration rather than decreasing the rate. If I am on DNS and still I have rapid drop, then only I will decrease the fluid rate because it's a lot of amount of renal dehydration. That's why I need to cut the fluid as well. If I'm able to alter sodium from half DNS to DNS, I keep changing sodium. But if I reach it to half DNS and I reach it to DNS, then I will try to alter the fluid. That is what I practice. It may not be correct for you also. You try to learn by yourself by modifying this. But the crux is you need to monitor urine output. You need to monitor sodium. Without this, you cannot correct hypernatremic dehydration. If you have a child with hypernatremic dehydration, these are two things you need to follow. One thing is frequent sodium monitoring and frequent vital monitoring, frequent output monitoring. If you don't have these three facilities, please refer that child. Managing the child within center and you don't have these facilities, you're going to do more harm than benefit for that child. Correct the shock, correct the acute retrovenous disturbance like hyperkalemia, do the bicarb correction, refer the child. If you don't have facility for frequent monitoring, that is what I can suggest. I hope I'm clear on this. If you have any doubts, we'll take, otherwise we'll end the session.